Okay, thank you very much for the opportunity to speak to the Pompe Society about nutrition and Pompe disease. As you're aware, I gave talks late last year for a Pompe preceptorship run by Dr. Mike Roberts, and this there will be some overlap, but I've also introduced some new material in view of the COVID-19 pandemic, which wasn't even, at least as far as we were aware, even on the horizon back then. Next slide. The first part, the outline of the first part of the talk, we'll just go a little bit about a little bit of background of nutrition and also body composition, what the body's made of, and the ways that we measure it, and then the ways that Pompe may impact on nutritional status, and many of which you'll be aware of, and how the disease manifests at different life stages, and then where the nutrition impact might be. I'm also going to show a little bit of information about nutritional interventions in terms of support and also therapeutic interventions, general and specific. And I guess they're the underexplored areas. And under that heading, I'm also just going to talk a little bit about the implications of COVID-19 for Pompe patients, potentially, and what aspects of nutrition that we've discussed during this meeting might be of relevance. Next slide when you're ready. Great. So the focus will be on nutrition assessment and also some of the some aspects of nutritional interventions to correct deficiency, to maintain function, but also nutritional therapy to alter the underlying disease course. This is a photograph taken in somewhere where those of you who come to Salford will be quite familiar with. This is our outpatient area, and some of you may have been to outpatient area 6 and recognized the weighing scales, but wondered what that machine in the corner was. Well, actually, it's a machine which can measure body composition, and specifically actually measures total body water, and therefore water in muscle, and through sophisticated calculations can then produce a set of figures which will give us an idea of total lean mass, fat mass, body water. And if you have a waist circumference measured, it can then compute how much fat you have around the middle. So this is something which is really a useful and emerging clinical tool, but we're just exploring its use in our patient population at present. Next slide. This is highly technical, but the big picture is there are lots of different ways of measuring body composition. The machine you just saw in the previous picture is actually similar to what's used in gyms, except it's a top-of-the-range medical grade version. Anthropometry is the old-fashioned tape measure, your height, weight, and skin fold thicknesses, and waist circumference. Impedance is a term in physics. Those of you who remember your physics from secondary school might remember the concept of impedance to current, but essentially, in really simple terms, in the body we have water, and the water we have in our body actually is not pure water. It's actually got salt. It's salt and water, or salts and water. And as we know from secondary school experiments, if you add salt to water, you can run electric current through it. So that's the non-fat, and fat is an insulator and will impede the transmission of current. And so that's another way of being able to measure body fat. Some of you may have had a bone density scan, that's known as DEXA scan. It's been originally developed for measuring bone density, but it can also measure body composition, in particular measure body fat and lean body mass, because the x-rays get stopped by differing, depending on what you're trying to put the x-ray through. There's more of a barrier to x-ray transmission depending on what it's having to go through, and that's why bone will show up on an x-ray, air is just black, and this will show everything in between. And the bottom are two super specialized methods, which have only been really used in reference laboratories around the world, and one is to measure total body nitrogen. It's a way of directly measuring body protein. And there's also a very fancy technique called whole body gamma counting, which measures total body potassium. Well, that assumes, apparently, and I'll just tell you this anecdote, because a colleague of mine was working in Sweden to learn about this technology. And the assumption is that because potassium has a normal component, and then there's a radioactive isotope, which we normally have in tiny, tiny amounts, but it lets off gamma rays. And if we can measure these gamma rays, then we can estimate how much potassium's in the body. Well, sometime around the mid-80s, they started to get the Swedes started to get some really strange results in their lab. And it was their neighbor, a bit over the border, that had some cesium and a few other isotopes which were causing weird results. So it is prone to interference. Next slide. These are the old tape measures, skin fold calipers, and the device at the top is for measuring sagittal height, which is how thick the body is from the back to the stomach. And it's another way of measuring central body fat. And these are low-tech, but well-established methods in specialized labs. Next. This was taken by the lab we worked in Melbourne, and this is the most simple form of bioelectrical impedance, which was, I guess, in use about 30 years ago. And you just run electric current between the hands and the feet and find out what the resistance and the impedance to current is. The machine that I showed you right at the beginning is a top-of-the-range contemporary model that's incorporated that technology, but looks at all four limbs and also looks at current going through the trunk as well. So, but the principle is the same, is that this really measures water, because water lets electricity go through it, and fat is the difference. Next slide. I mentioned the bone density machines. If you've got one that measures whole body DEXA, and the one at Manchester Royal Infirmary does do that. This one's was taken from our lab in Australia when we were there. But it's actually pretty good. It does measure the total, but it also does do a breakdown of trunk fat, arm and leg. So it's quite a simple way. And I think the advantage for people who aren't very mobile, you can, you lie down to have a body DEXA, so it doesn't require you to stand or stand for long periods of time. And you get a lot of information from the one test. Next slide. This is a bit technical, but in clinical settings, we see, well, I guess there's the issue of overfeeding, but we see the issues of undernutrition. And the term injury is obviously seen most when people are ill with, an infection or major surgery, burns, trauma, but, fulminating viral infections. And even in other chronic diseases, there can be a lower level but persistent inflammatory response, which may incorporate some of the features of response to injury in body physiology. Next slide. So what does this mean for the Pompe population? Well, obviously, when we compare methods, they're usually based on the general population. And the tricky thing about metabolic disorders and storage disorders, which is the very old-fashioned term for lysosomal disorders, is that by definition they are an alteration in body composition, and it may be with some conditions, other lysosomal disorders we have found slightly different results for different methods compared with the general population. But it's an excellent first start. And the methods that I've showed you at the beginning, like the impedance and the DEXA, I think would be fairly robust in Pompe next, and they have been used as well. So I'm going to talk a bit about diet. This is, I was at the Turkish Inherited Metabolic Disorders and Clinical Nutrition meeting last April, and this was an excellent example of a Mediterranean diet. Next slide. So just a bit about food components. Sometimes, popular information on nutrition sometimes oversimplifies nutrition and food. And food is much more than fat, protein, carbohydrate, fiber, and water. In fact, in the 19th century, the research which began the discovery of vitamins and minerals was because, having isolated fat, protein, and carbohydrate in pure forms, the scientists fed these to mice, and the mice died. So clearly, the micronutrients are there to help us utilize the main components of food. And from a metabolic point of view, micronutrients actually are there to facilitate a whole range of metabolic reactions, and deficiencies of many vitamins and minerals can actually mimic metabolic. They can mimic inherited metabolic disorders, but they're acquired metabolic disorders. So vitamins and minerals, if you've got deficiencies, many enzymes don't work, and you can have problems. Now, there's a big group called non-nutrient phytochemicals. Now, up to about 30 years ago, a lot of these were considered nuisance compounds that sometimes poisoned cattle or sheep, or were anti-nutritional. But from the probably more like 35 years onwards, from the 80s, mid-80s onwards, there was increasing awareness that these compounds were in the human diet, were found in human body fluids, and furthermore, subsequent research has confirmed that these compounds do have biological properties, and in many ways they have they're almost at some level like low-level pharmacological agents. They modify many of the physiological processes which can have significant impact on health and disease, certainly at a population level, and emerging data at an individual level. And then you've got your additives, things that are in food which have been deliberately put in there, and contaminants, things that are found in food that weren't ever meant to be there but just are. And I think we're all familiar with those. Next slide. So when we look at nutrition in general across the community, there are certain groups that are at greatest nutritional risk. And of course, the risk is going to be greatest if people are in overlapping categories. So obviously, the very young, teenagers, pregnant women, the elderly, people in institutions, and people who are poor, who can't afford to eat properly, and people who are taking obviously illicit drugs, that's understood, but actually many prescribed medications can influence nutritional state and, for example, can result in loss of nutrients or affect absorption. And for example, the proton pump inhibitors, widely used, can interfere with the absorption, say, of magnesium. Chronic renal, liver, gastro diseases obviously can do that, and disability. And I think in metabolic patients as a group, there are many who actually tick those boxes without even considering any of the specifics of the disorder itself. Next slide. So in Pompe disease, some of the things that are a potential influence, if you think about what are barriers to nutritional status, swallowing, obviously there's disability is there. So the ability to purchase, prepare, and then chew, swallow food. Breathlessness makes it harder to eat, and because muscle dysfunction can also affect smooth muscle of the gut, that can affect gut motility. In the lysosomal disorders as a group, there does appear to be activation of inflammatory pathways, which can influence how nutrients are handled. And obviously, if people aren't very active, people need to eat less. And when you eat less, the amount of micronutrients, vitamins and minerals that you get from food is proportionately less, unless you really make an effort to have foods which are very rich or take a supplement. And obviously, being more restricted in mobility means that you're more likely to have an indoor lifestyle, particularly if people have been shielding. So that exacerbates the risk of low vitamin D. And if people can't exercise, there is the risk of increased fat, but at the same time decreased muscle. And on the top of, with Pompe, there is that lot of inflammation of muscle. And then obviously there's a risk of bone loss with that as well. Next slide. So what how might the nutritional status impact on Pompe disease? Let's just talk about micronutrients. Obviously, if there's an imbalance of calories into energy expended, there's an increased risk of weight, which means that there's, as the muscles there may be more weight than the muscles are able to carry easily, and that can increase the functional disability. In terms of protein nutrition, it's really important to ensure that this is at the very least adequate. And protein can be used as a source of energy as well, and may have some role in Pompe disease. Carbohydrate, on the other hand, it's a source of glycogen. And of course, glycogen is in two parts of the cell. It's in the cytoplasm, where it's available as an energy source. But surplus glycogen that's not utilized then ends up in the lysosome. And if you cannot degrade the lysosomal glycogen, as occurs in Pompe disease, then there's an lysosomal accumulation, and then that can aggravate the disease course. So there have been studies done really over 20 odd, 10, 20, 15, 20 years, looking at the role of restricting carbohydrate as a way of substrate reduction in Pompe disease. And then the sort of next step beyond that, people have been experimenting with ketogenic diets, where in fact, really depending on fat as an energy source and having a normal to increased amount of protein and very restricted carbohydrate intake. It is much more restrictive, and there are potential risks of bone loss. And the questions that we would ask is, yes, it may help this, but it's really important to not just be trying to treat a condition, but it's about the whole person, you as an individual being as well as possible. And that needs a broader approach to nutrition. Next slide. Thank you. Vitamin D is a big deal, and those of you who come to our clinic will have all had it measured. And it's really something that I think we're quite passionate about. Vitamin D deficiency is really common in Britain. And if you actually look at where the UK is on a world map, and let's look specifically at where Manchester is, because that's where obviously our Salford clinic is, we are nearly 54 degrees north. To go that far south in the southern hemisphere, there's an island partway between Tasmania, off the bottom of Australia, and the Antarctic. It's called Macquarie Island, and only penguins live there. So we are abnormally close to the pole. And vitamin D is synthesized from sunlight. So it depends on sunlight exposure. But I think vitamin D, most people would know it's important for bones. It's actually also really important for muscle function, because vitamin D is needed, amongst many things, to absorb calcium efficiently. And calcium is needed for muscle contraction. Vitamin D is also needed for phosphate, and phosphate's also needed for muscle contraction. So you get muscle weakness even with quite mild degrees of vitamin D deficiency. So if your vitamin D is low, say even if it's below 75, and most labs, our lab says 50, but if it's insufficient or deficient, you get decreased calcium absorption. And consequently, this can have impacts on bone density. If the vitamin D is below 25, people generally feel rubbish. You get bone aches and pains, muscle weakness. And importantly, you can get immune deficiency as well with low vitamin D. And vitamin D over 100 starts to really influence the immune function. In theory, the data is there. things like multiple sclerosis, autoimmune diseases are more common when populations that are vitamin D deficient. Now, highly relevant at the moment is the relationship between vitamin D and immunity, because vitamin D is really important for what we call the innate immune function, which is the part of the immune system that's ready to take up any challenge. There's what we call the innate, which is there, and it doesn't matter what you've been exposed to. And then there's a specific immune system, which is based on recognition of old culprits. So one of the issues with the COVID-19 pandemic is because as a population, we've not been exposed to this virus before. Maybe some people in the population have been exposed to related viruses, but essentially we've not been exposed to this virus. Therefore, we're really dependent on our innate immune system. But if you go for extremely high levels of vitamin D, blood concentrations, there can be some sort of other effects that you might not necessarily want in Pompe. So the really big message, and in fact that's borne out in data on respiratory infections, that you want to correct to low level. So a vitamin D between 75 and 100 is a good place to be. You protect your bones, you've got good immune function, and you know, you should avoid muscle weakness from that particular cause. Next slide, please. We've actually had a bit of a look at our large population of patients with metabolic disorders at Salford. And, you know, while we know that if people eat less, you're more likely to get deficiencies, if people eat junk food that lacks vitamins and minerals, you end up with a surplus of energy, but still a lack of vitamins. We've had students go through the nutrient results that have been taken, the medical students who've been learning about rare diseases, and we found commonly low levels of folic acid, zinc, and even vitamin C in our patient population. And this is metabolic patients in general. Next slide. So we had a student 3 years ago. Her name was Aisha Sultangos. I think she's a doctor. But she spent a month with us, and she looked at all the vitamin C's that we had ordered. And admittedly, we did it when we suspected people might need the level checked because there was some concern or other. But actually, of the patients that we assessed, half of them had a vitamin C level that was under 10, which is diagnostic of scurvy. A quarter, it was borderline, and another quarter had a low level. There was one patient who had a clearly replete level. Next slide, please. Vitamin C is really important for obviously wound healing. It's important for mood. It's important for gut function because vitamin C is, I think, classically known if deficiencies will cause bleeding gums and red spots on the skin because it means that the blood vessels are more fragile. But it also is important for making neurotransmitters. So the early reports of sailors who had low vitamin C they got an absolute lassitude, apathy, very flat mood. And they also often have vomiting of a clear fluid. And that's almost certainly in part because the brain chemistry was affected, because you need vitamin C to make neurotransmitters, chemical messengers in the brain that affect mood and also incidentally affect gut function. So we had a look at, you know, the nature of those patients, but you know, there was really quite a spread. Certainly, you couldn't predict it on people who had low food intake. So the quality of the diet was probably more important, but where dietetic assessment was done, they did have a poor intake of fruits and vegetables. Next slide. So clearly, at a basic level, it's important to correct any deficiencies to avoid any aggravation. to effects of the disease. So that's obviously where micronutrients do come in, because of a range of functions. Zinc is also important, wound healing, protein nutrition, immune function. It's also important to ensure that people have enough calories and enough nutrients just for general maintenance. And that's where sometimes nutritional support is given, either as a drink, through a tube, and as a supplement on top of what people normally have. Next slide. I'm just going to talk about some of the dietary measures that have been used in a therapeutic way. Now, I had the privilege of meeting Dr. Slonim it was in 2002, actually. He's originally from Melbourne, Australia. He must have been back home. He came and gave a talk to our department, and he was talking about glycogen storage diseases. And he was telling us how with muscle glycogen storage disease in the past, people had restricted activity, but he was a proponent of graded exercise. But the other thing that he talked about was having, I guess, a balanced macronutrient composition. So in your typical Western diet, 40% of the calories would come from fat, but you'd probably get around 12 or 13% from carbohydrates, say 10 to 13% from protein, and commensurately more like 40 odd percent, 45% from carbs. So he was doing studies in Pompe with a diet that was around 21% protein, 43% fat, and less carbohydrate. Interestingly, the traditional Mediterranean diet of Crete, which has been shown to be associated initially with reduced coronary heart disease, but in fact, in numerous studies has been shown to be protective against numerous other health problems, including even cancers, and as well as heart disease and a variety of inflammatory conditions. So traditional Mediterranean diet is something that's palatable and actually quite similar to this. Next slide. So this was published in 2005. And these were two brothers with Pompe at age 20 months. The first slide is at age 20 months. The second slide is at age 16. And these brothers were given a diet similar to what Slonim was advocating. And this was a reduced carbohydrate diet with sort of higher protein and sort of an average fat intake. And you can see the difference in the two in terms of reducing the accumulation of lysosomal glycogen. Now, of course, once enzyme replacement therapy became available, the nutritional manipulations seem to have fallen a little bit into the background. But there are a couple of things to consider. In many diseases in adult medicine, we don't just rely on one treatment modality, we have more than one. We try and approach things two ways. So is there an opportunity for combination with enzyme replacement therapy to achieve a better result? And a sad but practical issue is that during the COVID-19 pandemic, because of the requirement to shield, some of our patients and also around the world have had interruptions to their enzyme therapy. And that's just so they don't have to have, obviously, an outside person coming into the home if they're needing to, protect themselves as much as possible and self-isolate. But the question is, could we diminish the damaging impact? We don't have the studies to confirm this, but I think it's an interesting question to ask. Next slide. And this goes back that glycogen breakdown either needs functioning autophagy, which is the way that the lysosomes get rid of stuff, or you need glycogenolysis, which is the usual way for breaking down glycogen as an energy source. Next slide. This diagram was only published last year. It's in Tarnopolsky's article, and I love the title, Autophagy in Mitochondria in Pompe Disease. Nothing is so new as what has long been forgotten. And this just shows the diagram where it shows glycogen going to lactic acid as an energy and generating energy in the process versus going via the lysosome and relying on the autophagy pathway. Next slide. And this is obviously demonstrating how that autophagy works when lysosomal function is working. Next slide. And here's another pretty slide, but the key thing here is that Pompe, yes, it's a lysosomal disorder, but disorders in one organelle frequently have impacts on the balance and all the cross-trafficking between other organelles in the cell. And so, you know, a problem in one area of the cell can lead to dysfunction in other areas of the cell. And in particular, the autophagy, the way that components of the cell are recycled, is actually pivotally influenced by energy balance. And I think, you know, the simple analogy is if you think of the lysosome as the cell's recycling center, if there is a shortage of resources in the cell so that energy is not in surplus, the recycling processes, the autophagy is upregulated. It's more efficient, it's more effective. But if in fact there's no shortage of energy in the cell and there's no need to recycle, then those lysosomes will become like the garbage bins that in our recycling bins that we had during the period of lockdown without the collections to collect them. So the energy balance is actually of emerging importance in lysosomal disorders. You clearly don't want undernutrition, but nor do you want overnutrition either. Next slide. So, and then there's this balance between too much or too little autophagy, and either way you need the right balance to have healthy muscle function. Even more so in Fabry, in Pompe disease. Next slide. So this slide was from Tarnopolsky's paper, and essentially this vicious cycle of impaired recycling or autophagic or blockage of autophagy in the cell leads to accumulation of damage in the cell and increased oxidative damage, and then that messes up mitochondrial function. And the mitochondria are needed for energy, so you don't want them damaged. So that's a difficult process, but his group have been looking at a combination of exercise training, both aerobic to burn off energy and resistance to build strength and remodel muscle cells, as well as supplementation with micronutrients, protein, and specific components of protein, amino acids, with a view of trying to slow down the progressive deterioration of skeletal muscle, which ultimately leads to cardiorespiratory weakness and mobility problems, which we're all aware of.
Well, thank you, Gisela. That was incredible. A very comprehensive presentation. But I'll certainly have to watch it again a few times, I think.
Have you ever looked at intermittent fasting as to bring into your way that you actually sort of reboot your system? Has anyone looked at that, or have you got any views?
Yeah, I think there are pluses with intermittent fasting. If in the strictest term, there are pluses and there are minuses.
Okay.
I mean, on the plus side, by I guess turning off calorie intake, you're actually dropping insulin levels.
Yeah.
And when you drop insulin levels, then you're not synthesizing glycogen, you're promoting the burning of fat. The only thing is that if you do the full fast, then you're also potentially breaking down muscle, and you may actually be triggering systems to perhaps become more energy efficient. So it may work for some, but there is also the risk of muscle loss.
Right.
But there is something which has been around, I guess, in the weight loss literature for a long time, and that's called modified fasting. And that's actually where and this has much better results in that you give a high protein supplement where you compress the protein intake into a fraction of the energy requirement,
right,
with all the micronutrients. And that way you at least preserve the amino acid pool. So even though you will be breaking down amino acids during that, severe calorie restriction, you will at the same time be repleting them.
yeah,
So, but what you don't want to risk, if particularly when exercise may be a limitation, you do not want to accelerate loss of muscle.
so
I think the caution.
you could take a protein like casein or something, which is a slow release protein that you could take when you're fasting. Is that what you're saying?
Yeah, so there have been medically appropriate, protein supplements that are low calorie and high protein with micronutrients that could arguably be used to help bring that. Because I recognize also when your overall energy expenditure is limited, you're having to compress all the good nutrition into a smaller calorie package.
Yeah. Good. I take casein overnight time, and it stopped all cramping and all. I used to get a lot of aching in the thighs and legs, but I don't get that at all now.
Oh, that's interesting. Yeah. And it may also be, when people, if your general energy intake is lower, it can be harder to maintain that protein intake and nutrient intake. So it's a way of looking at that. But I guess, which centre are you in?
Centre?
Yeah, which?
Queen Square in London.
Queen Square, yeah. Because they're a group with a lot of, active research interests.
Yeah.
So it's something to discuss with your clinicians, and maybe that's something that they can monitor, or maybe that's something we should do collaboratively and just answer the question, because it's when people have clinical questions like this, it's important that as clinicians that we have an answer based on observation and not just speculation.
Yeah, I think you've got to tailor it to each individual needs, because we're all at different levels.
Absolutely.
Yeah,
Absolutely. No, thank you for the question.
Okay, no problem.
Last time I spoke with Dr. Slonim, he said that it would be good to make sure to consume some protein at least every 4 hours. What's your opinion of that?
Well, the logic for that is, in fact, protein utilization, protein turnover is continuous. And so we're constantly breaking down muscle and replacing. So it's happening as a continuous process. So, the question I asked was before about intermittent fasting. Like if you go for a whole day without having anything, then you'll break down protein during that time. So in fact, you get more efficient use of protein if you do spread it out during the day. And in a completely different setting, in Asia, for example, where and I was there in the very late 80s. People obviously don't eat the quantities of meat and animal protein that are eaten in Western societies, but people actually eat it well distributed throughout the day. And that almost certainly means that you get much more efficient utilization of protein, using it for growth and repair rather than just breaking it down as an energy source. So, the other thing is that obviously if you have inadequate calories, you will just break down protein as an energy source as well. So if you're inadequate protein or just inadequate calories, but if you have inadequate calories, but at least keep that protein pool topped up, then that can sort of minimize the impact. But that would be, I would concur with, that's practical advice. Obviously overnight it may be less practical, but there's no downside to it, provided you're within sensible limits. Yeah, thank you.
I'd just ask a quickie about something I noticed on one of your slides. You showed the muscle biopsy, and you said it was a glycogen storage disease type 2B, which by my reckoning is Danon disease. Is that, I mean, there used to be a misconception about A, B, and C being sort of infantile, juvenile, adult. Medically, type B is Danon, I think. Is that not right? Do you know where that came from?
Yeah, well, I mean, that's from the slide, but I guess it's, I mean, sometimes these talks are, I guess, proof of concept.
Okay.
And I think it's just, I think the concept that was in the paper,
so it
was to illustrate,
okay.
you know, so even the specifics are that the concept is there, that there is the potential to reduce that, and that's the methods that Sloan was using. And he just didn't, the thing is, he didn't just use it in Pompe, he used it in a whole range of glycogen related storage disorders. So he used it in all the muscle glycogen storage disorders.
Danon's incredibly rare, isn't it? But
yes. Yeah.
I just wondered if it was an error from somewhere. But yeah, okay. It was very interesting to hear you talk about vitamin D, because, of course, the government and NICE, who was it, or Public Health England, made some pronouncement that there was no evidence to suggest it would help with COVID-19. Did you hear that?
I'm afraid I did. And then they cautiously suggested that maybe it was a good idea just to take a very low level, you know, the very basic level of supplementation. But I will discuss why I beg to differ. First of all, as I guess those of us in the rare diseases community understand totally a new disease, which is like a rare disease because we're still learning about it. But there is a meta-analysis of a large number, about 38 trials, looking at vitamin D supplementation in vitamin D deficiency, and that showed that if people are vitamin D deficient, you could reduce the risk of a respiratory infection by regular vitamin D supplementation, and that's been peer-reviewed, published. So that's not COVID, that's just in general. The other line of evidence is that if you actually look at the groups who've been most affected, and if you look at the season, this is the circumstantial evidence. Back in February, March, it was absolutely ripped through China, ripped through Iran, people veiled, dark-skinned, covered, ripped through Italy, where interestingly, despite its latitude being somewhat more favourable than ours, vitamin D deficiency is common, particularly in the older population, and there are publications to support that. Vitamin D levels are lowest in late winter, early spring, which is when this pandemic absolutely ripped through Northern Europe and Southern Europe for that matter. Vitamin D has disproportionately affected people whose skin colours are darker. And while there are many people talk about socioeconomic factors, but you know, doctors a bit, but if you look at NHS workers, disproportionately affected. We know, because we measure vitamin D, that the population is mostly severely vitamin D deficient by the end of winter, if they're not on supplements. So this is all circumstantial. And then furthermore, there are now some studies coming out. There's a paper that's come out of Newcastle, the RBI at Newcastle on Tyne, where it's obviously one of the very quick, a very quick research publication, where they measured vitamin D on every person who came in with COVID-19. And then looked at who went to intensive care and who didn't. And the younger, obviously, intensive care was populated by younger people, and that's clearly a selection bias. But they actually had lower vitamin D levels, the ones who were in intensive care, despite being young. So it's the circumstantial evidence is getting a bit stronger, and there are other. So that I would say that's an area of emerging evidence. But given that data on respiratory infections, given what we know about immune function, and then the other thing about vitamin D supplementation that probably does muddy the waters is that the practice in the UK, if someone has a low vitamin D level, what the general GPs do is to give loading doses, and then the vitamin D is fine, go away. But actually, the vitamin D deficiency has developed because of a long-term risk factor. And if people have the risk factors for becoming vitamin D deficient in the first place, and those risk factors are not modified, then that's a risk of recurring. And in fact, the data, people who had bolus doses, high dose of vitamin D every now and again, didn't get the benefit. It's people who took it on a regular basis, whether it's weekly, whether it's daily, whether it's weekly, but the key thing is to take it regularly. The authors of the paper suggested that maybe the swings to extreme level of vitamin D might have caused alternative immune functions, which may not have been protective. But I'm going to make a very prosaic suggestion based on experience. When people have a bit of vitamin D every now and again, there are long periods of time when they're deficient again. So they're not getting that even coverage. So, and the last thing I heard was that they suggested 400 international units of vitamin D. That's okay if you're going outside. In winter, if you've got no sunlight exposure, you need about 800 to maintain vitamin D. And that depends also on your body size. Yes, thank you for the question.
Yeah, and would that be vitamin D2 or D3? I think D2 is the stronger, is it? Or...
Oh, actually, there's cholecalciferol is strong, but then there's 25 hydroxy 125. So there are two forms of it. Vitamin D3 is the animal form, and vitamin D2 is the type you get in mushrooms, which is actually a little bit less effective, but it's vegan friendly, and because vitamin D is made from sheep's wool grease, as I explained to a vegan friend of mine. So I think, so for them, the solution is to go out in the sun or have the other form of it.
Yeah, I do both. I have done for a long time. But,
yeah, excellent.
Okay. Sorry, anybody? Oh, Barbara's got a question.
I have. Further to discussion on vitamins, we're all giving very conflicting advice about whether we should take a multivitamin or not. And you mentioned quite a few different things within your talk, zinc, D, iron, A and C, for example. How do we, even when we haven't got Pompe disease, how do we decide whether we need to take these multivitamins or not? And do you recommend that all Pompe patients should take a specific type of vitamin supplement that combines all of the things we require?
Look, that's a brilliant question. And I think we don't, the vitamin supplements and mineral supplements work best when they're correcting established deficiencies. And in theory, if our diet's perfect, we don't necessarily need that. But actually, a lot of minerals will depend on the soil. So things like selenium and iodine, very dependent on local factors. The other thing specifically for Pompe patients, though, is that because energy expenditure is reduced, food intake needs to be reduced, and therefore there is a greater risk of deficiencies if you're not able to ingest a wider range of nutrients. I mean, in an ideal situation, and certainly in the clinical situation, we do monitor. And if people's levels are fine of the key nutrients that we've tested for, then we don't necessarily recommend a supplement. If it's, say, something like D, we'll just do a targeted supplement. But if people have got a low in several things, we try and address the underlying cause, but sometimes that's not always easy or practical, in which case, even for a period of time, a multivitamin mineral supplement. And what you really do is, it's not about having mega doses. It's just perhaps if you're otherwise reasonably healthy, just considering whether or not a top up would be of benefit. But the jury, I mean, it is a complex area, but it is important to avoid deficiencies of specific nutrients.
I was thinking when you were speaking just then that most people don't see their consultants all the time, and yes, you have a blood test then, and GPs don't tend to be very proactive with anyone with Pompe disease, going from experience with our son. And, would it be a good idea for everybody to target the GP to give them more regular blood tests?
That is, look, I think there's a really, I could get myself into hot water here, but what I could say is that I think there are some nutrients that I think it's reasonable if people aren't getting, say, vitamin D checked more than once or twice a year. So once or twice a year, I think would be enough. Once in summer, once in winter, just to really, or spring and autumn perhaps, just to make sure, because that will give you an idea of the excursion. If it's less frequent than that, it wouldn't be unreasonable to ask the GP once a year, say at the time 6 months away from the consultant appointment, if it's an annual consultant review, to get some of these things checked. And I mean, for women, you want to check an iron level, because iron's really important for muscle function as well, and low iron levels cause fatigue. And vitamin D is very reasonable to ask for. Zinc, we actually see in the north of England, a lot of low zinc levels. Like most, it seems like a huge proportion of our clinic population have a level that's about 20% below the bottom end of normal. And I think it's probably due to food choices. So it obviously will depend on socioeconomic factors as well. But I think for selected nutrients, it's not unreasonable. And then, you know, folate is just quite a good, it's very easy for GPs to get done. B12, you don't want to miss a low level. But, you know, I think selected nutrients, it would be unfair to ask the GP to do the lot. And we don't do the lot unless we really think someone's in trouble from nutritional problems, not just from Pompe.
Okay, thank you. That was helpful.
Thank you. Pleasure.
Any more questions before we let Gisela go back to work? Oh, Kevin?
Yes, I'm very interested in your body composition machine that you got.
Right.
Manchester. Can it tell the difference between muscle and muscle that's gonotropic and fat? So you got your 3 different levels there.
You know, that is a superb question. The answer is possibly,
Okay.
but to give a clear answer, we'll need to study enough patients with Pompe. What we do know, the machine also gives something called phase angle, which is a measure of cell membrane integrity as well. And that's another piece of information which the impedance machine, certainly it'll tell you how much water you've got in the body, how much water and fat, and muscle is by derivation. It's possible to answer your question more fully. We might need to do some research-based techniques to answer that question, but it's a brilliant question. Thank you for asking it.